Ehrenfeuchter is with the Philadelphia COM, College of Osteopathic Medicine. He practices in Atlanta. Interesting story, maybe he'll tell us just briefly about Philadelphia to Atlanta. But I'm real honored to have him here to help everybody understand what OMN can offer. So let's give him a hand for coming.
Thank you. There we go. All right. Number one, the brain can only absorb what the fanny can endure. Stand up. Everybody stand up. Half of you didn't move during break time. Get up. March in place. Picking them up. Put them down. Get the shear stress going in your arteries. Prevents blood clots. Right? Get your arms going. Arms up overhead. Stretch. Move. The insulin's kicking in. We know your blood sugar's dropping after lunch. All right, now sit down and shut up. All righty. I'm an odontologist, okay, DO who does osteopathic manipulative treatment as a specialty. And so what I wanted to talk about a bit today is where it all intersects. Where does OMT and opiate use intersect? I'm not going to stand up here and claim to be a drugless physician. I could not practice without the help of the opiates. I got lots of patients on opiates. That's heresy. We're talking about addiction, right? Now, why do we have them out there? Because we got nothing else. What do we got? Pain medications. You've got Tylenol, okay? Yeah. I break my ankle, sure, I want a Tylenol for that. Thank you very much. All right, we got non-steroidal anti-inflammatories. Not exactly the world's safest drugs, and there's a lot of people can't take them. And then we have the opiates, and we got nothing in between. You got non-steroidal, you got opiate, and not a darn thing in between. So what we need is something that's more powerful than a non-steroidal that is not abusable like an opiate. And the medical profession doesn't have that yet. So we're stuck with the damn things. All right? They are a fact of life. And I'm telling you, when I had my wisdom teeth pulled at age 40, by God, I had Percocet. All right? And I knew one of the reasons is I can't take the non-steroidals, otherwise I might have tried that first. But a little bit of kidney failure will prevent that. I'm a stage 3B kidney failure, so can't take the non-steroidals anymore. So you're limited sometimes. Well, that was interesting. Let's try that again. Da, 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 da. It's magic. I'll try anything. Aha, that time it worked. Yay. Do one of these, bam. Face it, our big problem is a blank screen. Imagine that it said death at the bottom of this page. All right? Our problem is people are dying.
So if it's this button right here, just
yeah, that's the one I'm pushing.
Oh, okay.
It doesn't like me. Be nice. Be nice. You got to talk to it. So, honest to goodness.
Okay.
I
See, I think you're pushing that.
No, I'm actually, okay. Nope, I'm up on that one. Push it again.
Okay.
See, it likes
okay.
you. Let me try a different finger.
Do that finger.
Let me try that finger, because, yay, that works. Okay, so if you look at some of the numbers, you've had a lot of numbers today. I'm not going to bore you with too many numbers. Problem is deaths in the United States. So here's some of the deaths. And I know our focus today is opiates, especially prescription opiates, but realize tobacco is a bigger killer than opiates are. But tobacco is kind of socially semi-acceptable. So we don't make a big deal about it. But you're on opiates, oh my God, we get all judgy, right? Still an addiction. Nicotine addiction, one of the toughest addictions to break. We got alcohol up there, almost as many deaths a year as the opiates. Just below alcohol, we've got the non-steroidals. 16,500 deaths a year in the United States, most of them from GI bleed. They're not totally safe drugs, and yet we hand them out like candy. Heroin, about 13,000. And I don't have it on the slide here, but handguns are right up there with heroin. About 13,000 deaths a year due to handguns. We're legislating against handguns right and left, right? Only the criminals will have, it doesn't work. Prohibition didn't work for alcohol, and FDA isn't working, DEA isn't working for opiates either. The benzos, 8,500 deaths. Coke, 6,500. Acetaminophen, how much hype have you heard about? You're gonna die if you take Tylenol. Your liver's gonna crap out on you. No more than 3,000 milligrams a day or you're gonna die, right? It's only 1,500 deaths a year, and yet we're worried about Tylenol. Alrighty. Then I said, okay, let's look at deaths from manual medicine. And I had to go digging a little bit to say, in the USA, in the past 100 years, how many people have died from some form of manipulative treatment? And the answer is 26. 1 every 4 years, on the average. How many deaths from osteopathic manipulative treatment in the last 100 years? Ready for it? None. The education level of the person providing the manipulative care increases the safety. So the better educated you are on any therapy, I don't care if it's OMT or opiates, the more appropriately you're going to use them. And the better you're going to be able to use them and know when not to use them. That's why it's so important to have these conversations with your patients. Okay, enough numbers. All right, if some of these things will work. I wanted to do, oh, here we go again. Electronics don't like me as a rule. I don't know. Try this thingy. No, that ain't working either. All right. Help.
Which one do you want?
Yeah, let's bring that one up first. See, this is what happens when you're in touch with the force, you know? OMT people are weird, and so, yes, I've embraced my weirdness, but yeah, things don't, nope, that's next slide. And yeah. Okay, can we cut and paste it into Google or something like that? Chrome? Technology is great when it works. When it doesn't work, it absolutely sucks. It's absolutely the worst. But yeah, usually the hyperlinks only work when you're in this mode, but I don't know. You were so kind as to put them in there. Now they won't play. Can we just paste it into Google Chrome? No. No? Something's wrong. Alrighty. While we're trying to get that to work, let me tell you what you would have seen. Ah, here we go. Now it's working. Yay. Okay. That's enough of that. Now, do you think that gentleman deserves an opiate? All in favor? All right. Why did his leg do that? This old-timers baseball game. This guy's got multiple myeloma, and his femur just gave out. It's a pathologic fracture, right on camera, right on TV, blam, there it was. And there's many more minutes of him trying to stand up and them trying to help him limp off the field on a bone that doesn't work anymore. So we have no problem using opiates for people with malignant pain. That's a non-issue. All right, let's go to the previous ones. We got to escape. Yep. Oh, you're getting good at this. There she goes. Now I am going to. This is tennis. I'm just going to. Here we go. It's going to happen right here. All right, I'm going to blow it up for you. All right. She is #1 doubles tennis player in the world. I absolutely love tennis. You know why? if you're going to stay in the game, all the medical care has to happen at courtside, so it's all on camera. Okay, they don't do that, baseball, football, anything else. They take you back in the locker room, you disappear, you don't know what happens. Tennis, if you have a chance of staying in the match, it happens right at courtside. Well, anyhow, when you're going up to net, when you're playing tennis, you come forward, you split, you stop, and then you hit your volley. And we're going to let this play just a little bit further.
And as she does,
Blam, down she goes. Now, all right, this is a knee. Notice, normal knee, the kneecap is here. Her kneecap is up here. She just ruptured her quadriceps tendon playing tennis damn near perfectly. Stuff happens. How many people think she needs an opiate? All right, yep, she's going to be hurting, she's going to have surgery, she's going to need an opiate. So opiates are appropriate pain medications in certain circumstances, and they're appropriate for a limited length of time in the post-op period. They're appropriate sometimes for chronic use in somebody who has terminal malignant pain. Now then, let's get back out of here. That went well. Thank you for the help with that, because otherwise it never would have worked. Here we go, get that back up again. All right. The reality is athletes get hurt, right? Best to avoid standing directly between a competitive jerk and his goals. I love these demotivational things. They're a lot of fun. It turns out there's a lot of stuff athletes can't take. This is from the 2017 World Anti-Doping Guide. And if you look at the narcotic list there under S7, it's just about everything. And everything's metabolized to that. So the reality is athletes that are under the World Anti-Doping rules for their sport, and tennis is one of them, cannot take narcotics and compete. Absolutely cannot. So what happens? They use OMT. This is Serena Williams. You can see it's the Australian Open last year before she got pregnant and took some time off. But there's a standing flexion test looking at, she was having a low back problem, trainer did a standing flexion test looking for innominate dysfunction. This is Andy Murray at Wimbledon last year, and this is a British osteopath doing a cross-arm, high-velocity, low-amplitude thrust technique for his thoracic spine, where he was having problems. All this is happening on the ground at courtside. No tables, nothing fancy, no benches, it's whatever you can do, sitting in the chair or laying on the ground. I love tennis. I love tennis. It's a lot of fun. I play badly, by the way. I took up tennis at age 55. And yeah, I'm an old fart. I'm 64. Took up tennis at age 55, and for some reason I love chasing that silly ball around the court. I don't know why, but it's a tremendous stress reliever. And what's really especially fun is you can put faces on the balls, right? And it's like, yeah, take that, Dean, fight. A lot of fun. A lot of fun. Good sport. All right, onward. So we said post-op pain control. This is a patient of mine. Yeah, he was an OMT patient before he got in the wreck, and his care continued in the hospital. He was on a ketamine semi-anesthetic drug-induced coma for about a month. Okay, do you think that he was drug dependent when he came out of said coma? Absolutely. But they had to have a plan for how do we get him off of there. Why did they have to do this? Because he did this to himself. All right, this is an internal decapitation. There's C1, and it's supposed to be attached to the skull up here. There's about a 1-inch gap between C1 and the skull. He was driving on the Pennsylvania Turnpike heading eastbound, and when he hit the end of the Pennsylvania Turnpike, it makes a big sweeping left turn to go to New York. 6 lanes of traffic making a left turn. He was in the Porsche in the left lane, and apparently he fell asleep because he went straight when all the traffic turned left. He was hit multiple times. The last hit was by a gasoline tanker. Witnesses there say his car tumbled at least 6 times end over end before coming to arrest. And when they pulled him out, he had this. What they did was surgically, they put plate and screws into his head, and it was an L-shaped plate. They put it down here and bolted his head back onto his neck. This man did not have any neurologic deficits. He was also tapered off of opiates over a period of about 3 months. And his biggest problem at that point was he couldn't drink anything without a straw. Think about not being able to tilt your head backward, right? Can't drink, right? And I'm sorry, drinking your tequila through a straw is just not as nice as being able to tip the bottle back. So, yeah. So there's places where the opiates are very appropriate, but you have to have an exit plan. You know, in the military, you talk about SEAL teams and things like that, right? They go in, it's a strike force. There's always the exit plan. How are you going to get out? You do the same thing with patients in the hospital. From the day you admit them, it's how am I going to get this patient out of here and how fast? What's the exit plan? Anytime you put somebody on an opiate, you should have an exit plan. Sometimes the exit plan is death. Again, malignant pain, somebody that's terminally ill. The only thing that's taking them off that drug is death. If you just got a broken leg, how long do you need that opiate for your broken leg pain? It varies from person to person. Some people don't need it at all. They're great with Tylenol. Other people, they need opiate. And some for a few days, some for a few weeks. It's individual. But the longer they're on it, the bigger the risk. You've already heard that today. Again, where does OMT fit in? Well, the athletes we talk about, athletic injuries. And there's a lot of information on the acute injury stuff. We know that pain in general triggers an inflammatory response. There's also direct nerve injury, peripheral nerve endings, substance P. The pain is sensed by afferent-driven pain pathways, which activates reflex, sympathetic, and somatic motor activity. And it turns out that OMT acts to inhibit all of that stuff and all of the after effects of those. So Philadelphia, they did a very lovely study. This was published back in 2005. It's a small study, but it was very nice. It was a double-blind randomized study looking at pre-op morphine and post-op OMT for pain control in elective total abdominal hysterectomy. So using surgically induced pain, standard fan and steel incision for all the patients. They all had basically the same surgical procedure done. They divvied the people up into 4 groups. Group 4 had pre-op saline and post-op sham manipulative treatment, phony treatment. Group 2, pre-op saline and post-op OMT. Group 3, pre-op morphine, try and take a proactive, let's prevent the pain from ever happening kind of approach chemically, and post-op sham, and then group 4, pre-op morphine, post-op OMT. So they either got saline or 10 milligrams of IV morphine 10 minutes before the incision was made, and they all received post-op patient-controlled IV analgesia pumps containing morphine. Subjects rated pain, nausea, vomiting, blood levels of morphine. They were all looked at. The OMT delivered was typically lower thoracic, lumbar, and sacral regions for less than 5 minutes or until release. So they didn't go over 5 minutes on anybody. And they did some very simple techniques: sacral myofascial release, thoracic myofascial soft tissue treatments, lumbar, call this rib raising, lumbar soft tissue techniques. The sham treatment was contact with the musculature with no direct pressure, no spinal extension. They put their hands there and they just kind of held on. And it's like, yes, I'm visualizing the patient improving, but they didn't do anything. They did about 3 minutes to each side of the spine, 4 hours after the return to the room, 8 a.m. on post-op day 1, 2 p.m. on post-op day 1. So each patient had 3 manipulative treatment sessions. They found absolutely no difference in pain scores or nausea and vomiting scores among the 4 groups. But the patients in group 4 used less morphine than patients in group 3. Now remember, both those groups got morphine, but group 4 got OMT, group 3 did not. So used less morphine. Also, patients in group 4 had lower blood concentrations of morphine than group 2. So the reality of this is the OMT seemed to potentiate the effect of the analgesic. The two work together by different mechanisms to reduce pain. Now, it didn't spill over into the pain levels, and this is one of the problems with that 0 through 10 pain scale. You've heard it alluded to already. I hate the scale, I really do. Because all of the people that are drug seeking, they already know. Well, if I tell the doc it's an 8, 9, or a 10, they'll give me my drug because that's opiate territory, right? 4 and less you can live with. In between moderate pain, that kind of 4 to 7, 4 to 8 range is kind of non-steroidal territory. Well, the reality is, everybody comes in and says, how you feeling, Mrs. Jones? And it's like, pain's terrible today. It's a 12 on a scale of 10. And it's like, okay, well, there is no 12. And by the way, 9 and 10 is accompanied typically by tears, nausea, and vomiting. And you don't have any of those. So I know you're lying. Or at least you don't know what a 10 actually means. So if you learn the physical findings, the thing, if you've got a 10 level pain, you should be hypertensive, you should be tachycardic, you should have other things that indicate that you're in pain. If you're sitting there looking at your cell phone going, yeah, I just a 10 today, doc, it's like, oh, bullshit. It's not. So the pain scales haven't been very good at picking up the effectiveness of anything. One of the great, they can only do this in research subjects. They've tried to use both dental extraction and also transitional labor pain as indications of what are the worst pains that humans can endure. And then they rate their pain medications against it. Another really good sadistic one that they use is they put a light bulb next to your arm. And it's a little rheostat. So they keep cranking it up so it's brighter and hotter and brighter and hotter and brighter and hotter until you say, I can't take it anymore. Then they give you a drug and they use the other forearm and they do the same thing. And they find out how hot can they make that bulb before you feel the pain. Those are nice objective things, but they're kind of sadistic. So we can't do that to people, really. One of the things I got to discover is a year ago this past spring. I developed an umbilical hernia. And so had to have the umbilical hernia repair. Well, umbilical hernia repair means 5 incisions. They're all each like a little half-inch long, but a couple here, a couple there, one in the middle, and then 4 places where they perforated through the abdominal wall to pin the mesh in place. That's lovely. And what I got was paraspinal muscle spasm in every damn dermatome that had a little incision in it. Okay, these things reflex back, and I don't know why, but this one was more painful than all the others. If you touched where this little bead came through the abdominal wall, it radiated right around into the back. So I called one of my friends and said, you got to come over here and just do some rib raising, just some soft tissue, loosen my back up. And I was actually very good. With the addition of OMT, immediate post-op, they had me on opiates. With the addition of OMT, I was good with IV Tylenol. So the hospital stay was IV Tylenol and OMT. I got home, I didn't have the OMT anymore. All right, went back up to, the first night was 2 Percocet to be able to rest comfortably through the night, second night 1, after that off of them. So short-term use, post-op, not a problem. These are drugs you have to be judicious about using, not drugs you have to be afraid of and never use. If we did that, we'd never do anything. Here's another group of people can't take opiates, right? You're pregnant. Shouldn't be taking drugs. Drugs are bad, right? To quote South Park. Drugs are bad. Pregnancy-associated low back pain. This article was published in where? American Journal of Obstetrics and Gynecology, the big OB-GYN journal, January 2010. Kendi Hensel, who's on the list here, was actually the principal manipulator in this group. They enrolled women during the 28th to 30th weeks of pregnancy, 144 subjects randomized to 3 groups. Standard care, again, standard care plus a placebo sham treatment or standard care plus osteopathic manipulative treatment. What they find? Significant differences in pain scale and even bigger differences in Roland Morris Disability Questionnaire to assess back-specific functioning. The reality is manipulation is a mobilizing modality. It will relax musculature and get joints moving. It will stretch fascia. It does that kind of stuff. If that's what you need, it works very well. If you've got a big-ass herniated disc sitting on a nerve, it's not going to do much. All right? So the problem with much of the osteopathic manipulative treatment research that's out there is patient selection. They're not being good about deciding, and we've done a very poor job as a profession of giving you, what are the indications for OMT? What do we tell you the indications are? Symptoms that could possibly be due to somatic dysfunction, which is everything. Okay? So that means everybody's a candidate. Clearly not everybody responds. So who is a candidate for OMT? And we've done a very poor job as a profession of actually detailing that out. The people that do OMT, we know that there are people who are poor candidates and people that are good candidates. How do we know? I don't know, but I know one when I see one. Is that dumb or what? But even the specialists in this field haven't been able to define what makes a good candidate. There's one thing we can all agree on, and that is you want a manipulative virgin. Somebody who has never had manipulation, chiropractic, physical therapy, or osteopathic ever before. They respond better than anybody that had manipulation before. Well, why did people have manipulation before? Because they had a pre-existing problem. So if you're coming into me and saying, my neck hurts, and I go to use manipulation on you, you may do extremely well if this is the first time you've ever had it. The number of times of manipulation, the response drops down. So if this is your 23rd time having OMT done on your neck, your response is going to be much weaker because you've got a chronic problem that isn't responsive to OMT. You got to find out what's wrong with this neck. I have a saying, and that is, weird finds me. Number one, because I'm weird and I've embraced my weirdness. I know I'm a little bit on that Asperger's spectrum, you know, it's very obsessive compulsive. If I stand and talk to my office manager for any length of time, I rearrange her desk. Yeah, so little behaviors like that tell me a little OCD, a little Aspergery. Don't get social cues very well. Oh, bad, yeah. Which may explain why I'm on my third marriage. But which brings up another thing too. Very typically, people who have substance abuse problems relapse. Smokers relapse. Alcoholics relapse. Opiate users relapse. I am the king of second chances. If I'm on marriage number 3, you're allowed to relapse. All right? And we'll start over. Okay? Why did the person relapse? Why did they get worse? Where do we go from here with this stuff? All right. Now, see if I can make this one work. I'm going to tell you a story about a couple of patients here. This isn't actually her, but she was a flyer for her, and I know this isn't very large, I hope you can see it. She was a cheerleading flyer in high school, and unfortunately something like this happened. Now you can hear him hit, you know? Oops. But that's what happened. She got dropped. And I know I'm nowhere close to the correct slide, so let me do. Here we go. So she got dropped. And here's what happened. She fractured her lumbar spine. So you can see fracture line here, and then if we go ahead one more slide, this is not true pars interarticularis fracture, it's sort of more a pedicular fracture here and over here. So we've got these fractures in the lumbar spine. They said they're non-displaced, everything's good, we're going to leave them alone, they'll probably heal. She was dropped in the summer of 2008. She was treated conservatively, non-surgically, for 3 years with no success. 2011, they decided to repeat the x-rays. She's now got a grade 1 spondylolisthesis of L4 on 5. The fracture never healed. Chronic low back pain, 3 years. She's now 19 years old. They did a surgical fusion on her, and it didn't work, so they revised it 2 more times. These are my typical patients. So I'm considered in the school and the region I am, I'm physician of last resort. You went to your primary care doc. He treated your injury with muscle relaxants, non-steroidals, didn't work, sent you to orthopedics. Orthopedics says, you know, you're not really a surgical candidate, or we did surgery and it didn't work, you need to go to physical therapy. 12 weeks of physical therapy later, they're no better, so let's try some acupuncture. Maybe a psychologist needs to work with you on your coping skills. How about 2 chiropractors and a faith healer? Now you're in my office. Okay, so I'm a resort doc. I am the physician of last resort. So I see weird stuff. I see people that are in chronic pain who did not respond in the acute care setting. All right, so by the time I got her, this is what her back looked like. You can see the fusion mass on either side here. This is a spacer to keep the vertebrae flexed. So they did an L4, L5 fusion. She's still in tremendous pain. I got to see her December 2016. At that time, she'd been pretty much inactive for over 5 years. She was 16 when she was dropped. Again, now she's 21 years old. 5 years of youth gone, almost totally inactive. She had been on nonsteroidals. They had to be discontinued because she got a bleeding ulcer from them. Her medications at the time I first saw her, fentanyl patch, 37 micrograms, and escitalopram, which is a selective serotonin reuptake inhibitor. As much for chronic depression as anything else. She was still experiencing severe back pain, so one of the questions was, does she have an occult infection? Does she have a failure of fusion? Or is hardware migrating? What the heck is going on here? So we did a radionuclide bone scan combined with SPECT, and it came back entirely normal, absolutely normal. So this, as far as the objective evidence we can develop on her goes, EMG nerve conduction velocities, imaging studies, physical exam, everything coming up with totally normal, except she has pain. But armed with this, there's no reason not to. There's no ununited fractures, there's no failure of fusion, no migration, no infection. It means that I could safely do manipulation and exercise with her. So started that. Just so you know what I did, number one, this poor woman was scared to death. She was afraid I was going to paralyze her or something. She was there because her family kind of dragged her in and said, you have to do this. And so I started out at the other end of the body. I started on her head. So I did some cranial manipulation. Honestly, I didn't expect it to do anything, but what it did was have the patient gain confidence in my ability to do things and not hurt her. And from there, I used some very gentle techniques and just started working my way down the rest of the body. Now, this was over the course of several visits. This isn't all at one time. It's a progression. You're moving progressively to more active techniques. Eventually got to muscle energy for the hip girdle musculature, segmental articulatory techniques above the lumbar spine, muscle energy in the lumbar segmental techniques, and she was tremendously constipated from the opiates for all this time. And so there's some lovely constipation techniques you can do on the abdomen. And they're really, really easy to do. They work very, very nicely. And so you teach them to the family. So taught the family how to do this. And it's like, okay, you know, a couple times a day, preferably after a meal when you got that gastrocolic reflex kicking in. You like coffee? Definitely go for the coffee. We'll get the caffeine, get you to take a nice little walk. Did you know the psoas muscles stimulate the transverse colon when you're walking? So you get up in the morning, you have a bite of breakfast, gastrocolic reflex, cup of coffee, go take a half-hour walk, you will have a bowel movement. Okay? So you can make use of the body's own mechanisms to treat this stuff. You don't have to automatically be on all these wonderful gut-stimulating and gut-destroying meds. They're tough. So anyhow, I was treating her about every 2 weeks for 3 months. We've now tapered off the monthly intervals. She's doing core strengthening exercises for the abdominal and lumbar strength, and I've recently added some shoulder girdle things for her. She's attempting to do these daily. I told her to do them daily. She's managing about 60% of the time. And I told her that's good. Nobody's perfect. All right? The reality is I kind of expected she wouldn't do it every day. So told her, do it every day. If I get a real obsessive compulsive person, I'm golden. They're doing it every day, right? If not, about half the time, 2/3 of the time, that's really actually pretty good. How do you know if they're doing, how do you know if a patient's doing the exercises you gave them? If you're using exercise therapies of any sort, real simple. You say, show me your exercise. I want me to make sure you're doing it right. Doc, you got another one of them handouts? I lost mine. It's like you were supposed to be doing this every day for the last 2 weeks. You don't have it memorized yet? You haven't been doing it. So, yeah, people lie. Life sucks, then you die. You know, it is. It is. So that's how you tell if somebody's actually doing them. Have them do the exercise in your office. Prove to you they know what they're doing and that they're doing it correctly. I'm amazed at how many people do them wrong and actually make themselves worse in the process. Outcome, where are we? because this is an ongoing case right now. This is real world. This isn't like fancied up or anything. This is what's going on with this woman. Her pain levels have been decreasing. Her activity levels are increasing. Socialization, getting out of the house, going to concerts and things with her friends, increasing. And as of October 13th, she's going to begin attempting to taper off the opiate medication. She is also under management by a pain specialist who's handling that side of things. So this is a success story in the making. I think she's going to be able to get off the opiates. I think she's going to be fine. But she's been on opiates for 5 years. Okay. Blank slide, what's that mean? Absolutely nothing. I don't know why it's there. Okay. That was a success story. Now let me tell you a failure story. This also was a patient of mine. She was up in Philadelphia, SC. 35-year-old woman, intermittent back and neck pain due to injury sustained in a motor vehicle accident. Her pain was well controlled with a combination of exercise, OMT, nonsteroidals. That kept her in okay shape. She was a hypermobile. She had a lot of stability issues with the spinal column. One day, out of nowhere, she developed severe pain at the base of her neck. A week later, her thumbs became swollen and painful, and within a month, virtually every joint in her body had become involved. Consultation with rheumatology was kicked in, revealed a diagnosis of inflammatory osteoarthritis, a disease so rare that it gets one paragraph in a 3,000-page rheumatology book. There's that much information on it. There are a grand total of 3 articles in the literature, mostly by residents who had to write a paper for their residency program. There is no research. Nobody knows anything about this disease, and it's an extremely destructive disease. Within a year, her hands looked like this. This is arthritis mutilans. Quite literally, this disease, this inflammatory osteoarthritis, is destroying the joints in her body and throughout her body. It wasn't just hands. It was neck, back, ribs. Did you know you have synovial joints where your ribs join the sternum? They were involved. Knees, shoulders, everything. So in addition to rheumatologic intervention, pain management was consulted, and pain management started her on long-acting opiates. This is where the debate comes in. Do you take somebody with a chronic, benign disease and put them on long-acting opiates? How do you control their pain otherwise? Do you just say, hey, you're totally screwed, suffer? Okay, malignant pain, not a problem. Short-term pain, post-injury, post-op, not a problem. Chronic, non-malignant pain is an area where the debate continues to rage. There is no consensus on what is the most appropriate form of treatment, so it's a judgment call. Her pain management folks started her on long-acting opiates. Very quickly, she found the opiates allowed her to escape not only her pain, but her life. She began obtaining more opiates from multiple doctors, and when that didn't work, she started buying pills on the street. Does this sound familiar? I've been hearing this all day. Her husband put her into rehab 3 different times, and she went back to the opiates. She relapsed each time. Finally, her family gave up on her. Husband filed for divorce, and the pictures that follow here just give you a little bit of insight into, you've heard the words, sometimes pictures as those little videos have a little more impact, because realize this was a functional human being. I'll talk about her life a little bit before opiates when we get there. I know this is hard to see, but you're looking at a linoleum kitchen floor that's covered in burn marks. This is where she dropped all those lit cigarettes, and the whole house looked like this. Furniture, rugs throughout the house. She was a smoker in addition to everything else, and the fire department had to be called to the house on 3 different occasions to extinguish fires that were started from neglected cigarettes. Imagine living with somebody like that, not knowing if you're going to wake up in the morning or wake up to being on fire because the bed's on fire or the house is on fire, you know, a little stressful for the family. She'd pass out, blackouts, found unconscious, collapsed in drug-induced stupor, and again, you know, aside from her, sitting over in here is one of those cigarettes, passed out in the kitchen. Here's passed out in the bedroom. Realize when you're in a drug-induced stupor, you have no control over the position your body's in. In addition to this, she fell down flights of stairs repeatedly. She kept hitting her head at the bottom. There were multiple dents in the wall at the bottom of the stairs where her head kept hitting. And she's still alive. She's still not breaking anything. It's amazing what the body will put up with. So why did she fall into this cycle of addiction and abuse? Okay, she had the arthritis, but really the seeds of this were all in her history if anybody had even bothered to ask. Nobody asked, they just did it. And this is where the mistake was made. So even though she went to a reputable pain management group and all that, they didn't really ask about her history. As a child, she had had major dental problems. At age 4, she needed repeated dental procedures which were performed without benefit of anesthesia. Now, whenever she gets into a dental chair, she flashes back to childhood. She's got PTSD, post-traumatic stress disorder. She flashes back. She is literally a 3 to 4 year old child sitting in the dentist's office when she's in a dental chair. Total panic. As a teen, she drank heavily, often being brought home passed out. She majored in alcohol and pills in college, that and pinochle. And after college, she quit the alcohol and drugs, but still suffered from unfocused anxiety and bouts of depression that were bad enough to cause her to miss work. Because she was working. She was a 911 operator with the Philadelphia Police Department. Very functional human being. But as a 911 operator, you get to listen to the worst that happens to humanity. People that are in the act of being stabbed and murdered. People who, you've got a child screaming and it's like, he keeps hitting the baby, he keeps hitting the baby. And you're answering the phone calls on these. So it's incredibly stressful. So she and the other 911 operators had a routine. After work, they would go out and get drunk. That's how they coped with the stress. So they really didn't have good coping skills, and they also didn't have a lot of help from their employer on that front either. That has changed, but at the time, that's how it was. So SC had been using alcohol and drugs her entire life to self-medicate her mental illnesses and her inability to cope with stress. So her descent into an addictive spiral was perfectly predictable. This is a person where when you get that history, you know you want to be very careful if you're even going to consider using the opiates at all. But nobody asked. You got to ask. You got to have the conversations. You've heard that many times today. 25 years ago, she tried to drive to see a friend. She has no memory of that drive, but she plowed into 2 state police cars on the interstate that were blocking the road because of an accident. 1 state trooper was killed, 1 will never walk again. So addiction doesn't just affect the person who's addicted. It impacts an entire community in ways you can't predict, can't even begin to understand. Rehab again, relapse again. As of this time, SC has not left her house for the past 25 years. She's also developed agoraphobia. She does not go outside. She has people come to her house to take care of her. She sits at her bedroom window, chain smoking and watching the world go by. That is her life now. She found a Dr. Feelgood, who will prescribe whatever she asks for. So she is still heavily addicted to opiates and benzos and God knows what else. She smokes marijuana on a regular basis. She is a true junkie. And she won't take her own life. She hates her life. She despises herself. She hates what she has become. But her religion says you're going to hell if you take your own life. So she won't do it. So she's really just kind of sitting there waiting to die. Real person. One more case, me. I was born with a whole bunch of congenital problems in my body. I've got a familial predisposition to heart disease. Every blood relative of mine has died of heart disease before age 70. Guess what I've got? Heart disease. Yep. We've got a familial type 4 hyperlipidemia. That means triglycerides run very, very high in my family. Fasting triglycerides should be less than 150. My fasting triglycerides are 1,400. Okay. I am heavily medicated for that. We also have a familial collagen defect that predisposes to premature degenerative disc disease. I didn't let that stop me. I'm a Philly kid, all right? I played in one of the Mummers string bands in Philadelphia. That's me in the middle playing bass saxophone. That is 40 pounds of very cold metal on New Year's Day in Philadelphia. The back piece weighs about 10 pounds. That's a lot of tension hanging on your brachial plexus. That's all I'm saying. And in case, it's not just me. I mean, there's lots of people to do this. Our band, you have 60 playing members that are allowed on the street, and there's probably more than 100 musicians overall, but only 2 bass saxophones. So there were 21 string bands. I'm one of 42 people that year who could claim to play bass saxophone in a string band. I've embraced my weird, yes. Okay, so yeah, I didn't let all of this stuff stop me. Life goes on. Age 16, I herniated my first lumbar disc. I made the mistake of sneezing. All right? You know how guys shave? You're standing at the sink? You're standing at the sink, and you cantilever forward because you're bleary-eyed and you're trying to shave, and right there, that's the highest intradiscal pressures in the lumbar spine, and I sneezed. Zing! Down the legs. Knew exactly what I had done when I did it, and so I hung on to the sink for a minute or two, and then I got up and went about my day. I re-herniated the same disc at age 40, working in my garden. Both herniations responded very nicely to conservative care. What was conservative care? The McKenzie extension exercises, which reduce intradiscal pressure, non-steroidal anti-inflammatory drugs, and osteopathic manipulative treatment. That was it. Herniated lumbar disc. 1982, after I completed my residency in OMM, my neck was asymptomatic, but everybody kept saying, you know, you really stand funny. There's something different about the way you stand. So I got the total body x-ray. I got the entire spinal column. Let's see what's in here. I'm just curious. And what I found was, among other things, I had a Swan neck deformity where you have a lordosis in the lower neck, but a kyphosis in the upper neck. And this is congenital. So I have a Swan neck deformity. What this means, okay, normally the AP curves in your spine are shock absorbers. So every step you take, they do this, they bounce, all right? You take some of that shock absorbing ability out there by straightening and reversing and shortening the curves, and it doesn't shock absorb anymore, so all of the force goes into the discs. They wear out prematurely. In these x-rays, I'm 29 years old. In these x-rays, I'm 37. This is the same neck, so before, after, before, after. You can see the degenerative disc disease, the narrowing, the osteophyte formation. This is looking uglier all the time. And I'm starting to have neck pain. So I said, hey, I'm young. I responded to non-steroidals and stuff before. Let's see what we can do with it. So once again, back to OMT. Alex Nicholas was the guy who was treating me. And the occasional non-steroidals when the pain got bad. 1997, I herniated the C4-5 disc and developed a C5 radiculitis. I was on the Back to the Future ride at Universal Studios. Like I said, I don't stop for anything. I just Energizer Bunny, just keep going. And you know, you're sitting in that DeLorean and watching the big screen, and the DeLorean did one of these things, and my head whipped side to side and buzz, down the left arm. Yep, blew that disc. Well done. Again, treated conservatively, OMT, non-steroidals, not working so well this time. Added in another exercise program, added in acupuncture. Trying to do this and do it the right way. Pain got progressively worse. I developed an additional C8 radiculitis. My physicians were still focused on pain control because I had 0 neurologic deficits. I had no numbness, no tingling, no muscle weakness, no reflex loss, no changes in spinal cord function, EMGs, nerve conduction velocities, somatosensory evoked potentials, all normal. You don't operate on people for pain unless they've failed everything else, right? So they're still trying other stuff. By July 2010, I was now on high-dose nonsteroidals constantly, gabapentin, which is an anti-neuritis drug, anti-seizure drug, and I was up to OxyContin 40 milligrams 3 times a day. I also had oxycodone immediate release, 5 to 10 milligrams every 4 hours as a rescue med, taking that 3 to 5 times a day. Again, I'm working full-time. You know, we were talking earlier about who's a potential addict? Every one of you sitting there. Every one of you sitting there. So we have a tendency to judge people. Like I said, I'm on marriage number 3. When I was sitting where you're sitting right now, I was on marriage number 1. And I was in it for life. And we had a baby on the way. And by God, isn't life good? And it took 20 years for the whole thing to go to hell, but it did. 15 for the next marriage to go to hell, but that did too. All right? And strong believer in marriage. I'm on number 3. Right? which makes life a little weird sometimes. But the point is, in all that, this is a progression, right? You look at life and you say, okay, when I'm sitting where you're sitting, if I had heard somebody was on their third marriage, it's like, oh, that degenerate, scumbag, right? What kind of guy goes through 3 wives? Hey, me. Okay, what kind of guy ended up physiologically addicted to opiates? Me. Okay, this is going on for years. All right. I had 3 attempts at fluoroscopy-guided epidural corticosteroids. The first one worked well for about a month. The subsequent 2 did nothing. I had a temporary spinal cord stimulator implanted. Absolutely no relief. I'm still going to work, seeing patients, teaching class, doing all the stuff I do. December 2010, I had surgical decompression and fusion of my neck from C4 to C7. And thanks to my lovely wife, number 3, for the embarrassing post-op picture. Yeah. That's what you look like. You wake up just after having your neck fused. This was my neck afterwards. And you can see they did a 3-level discectomy and anterior interbody fusion with both bone and metal implant. So basically my skull moves on C1, 1 on 2, 2 on 3, 3 on 4. 4, 5, 6, 7, all fused, and then it moves at C7, T1. So if you ever wanted proof that most of the rotation in your neck occurs up there at C1, here it is. Okay? Because much of the rest of it is fused. Side bending, on the other hand, that's it. All right? Because those upper segments don't side bend very much. Flexion extension, you'd be amazed how much flexion and extension is just up there at the top at OA. But also I've developed hypermobility in my upper thoracic spine. So I can get my chin down to my sternum, but about half of that forward bending is happening in the upper thoracics, not in the neck anymore. All right, so I had the surgery. The surgery was extremely successful. I woke up after the surgery and the pain is gone. 0, none. I mean, it felt so good. I needed no pain meds, nothing. I felt fantastic. The problem was I was still on these medications and I was physiologically addicted to them. So, time to start tapering things. So with pain management guidance, they said, well, drop your dose like every week and see how you do. So this is what I did. 40 milligrams Q8, 40 milligrams Q12, 30 Q12, 20, 10, and then I switched over to the short-acting oxycodone every 6 hours. And I was fine. Felt nothing, no withdrawal, 0. And then I hit this. Tried to drop it to Q8 hours, and bam, withdrawal hit. And I couldn't function, I couldn't think, I couldn't work. I very quickly went back on the opiates. To get this dose back up to where I can function, I have to function. I got a class to teach, I got patients to see, I'm a busy guy. So I did. And I knew that trying to quit cold turkey or rapidly the standard dose reduction schedules was not going to work for me. But I'm a real man. I can put up with a little discomfort for 5 minutes or so. So each day I extended my dose interval slightly. So first day, oxycodone 5 milligrams every 6 hours. Day 2, oxycodone Q6 hours and 5 minutes. Third day, oxycodone Q6 hours and 10 minutes, and so on. Every time I got beyond about the 6-hour, 15-minute mark, I would experience withdrawal symptoms. But if I knew there was a pill coming and not too far away, I could deal with it. I could cope. I want to tell you what I experienced. Generally, I was just a bit achy. Just kind of felt a little fluish. Okay? But I felt exhausted. Absolutely no energy. And I had diarrhea. Okay? Thank you, opiate constipating effects going away. So that was the physical side of things. That sounds pretty tolerable. What I never read anywhere, nor did anybody ever prepare me for, was the mental side. I was a worthless piece of shit. Planet would be a better place without me. I needed to lie down, but I'm not worthy of a bed or even an OMT table in my office or the floor, so I curl up in a ball under my desk and hide from myself and the world until I can have my next pill. This went on for about a month, and I gradually extended out the doses. Somewhere around 1 pill every 8 hours, it stopped happening. I continued the slow taper. I was terrified to stop it. So I just continued the slow taper out to every 12 hours. Once I got there, I just stopped dead and never had any symptoms again. By the way, the neck feels fine. I play tennis. I do all kinds of crazy things I probably shouldn't do, but life is good. I'm still this side of the dirt. Okay, I still have oxycodone in my medicine cabinet. It does not call to me. Okay? A lot of addicts who get the psychological addiction, those people where you flip a switch and somehow their brain is changed forever. It's like there's this little voice, take me, and it keeps coming from the medicine cabinet, even though it's there, but they don't really need it. But there's this craving, this need. I was fortunate, I didn't get that. Okay? Did I get the psychological, hammer? Yes, I did, but not anything else. Again, I needed a little bit when I had the umbilical hernia repaired. Like I said, I can't take the non-steroidals anymore because of stage 3B kidney failure, probably from all those years on the non-steroidal anti-inflammatory drugs. I've had kidney biopsies. They look pretty good. I don't have any other overt kidney disease. So thank you, non-steroidals, for killing my kidneys. But I have no cravings for the drug. It can sit there. I can have a bottle that'll last 2 or 3 years sitting in the medicine cabinet, then I throw it away, then I get a tooth pulled, and then I get another bottle, and it sits there for 2 or 3 years. So the opiates are a double-edged sword. They are an incredible blessing for pain relief. I couldn't practice what I practice without them. We need them for these acute injuries. We need them for the post-op patients and such. But they're a curse due to their potential for addiction and abuse. So this is where we're stuck. And are there any good answers? No, the conundrum is we've got no good alternative medication for severe pain. You go right from non-steroidal to opiate. That's it. Nothing in between. And just because an opiate is a weak opiate, something like tramadol, Ultram, doesn't make it less addictive. It's just now a weaker opiate. Still an opiate. So there we are. So before moving to opiates, you have to engage the patients in that conversation. This is going to help your pain, but it could be very, very bad for you. And you've got to know that going in. Now, you still want to try. Okay? We're going to monitor you very closely. If I see you getting in trouble, they stop. Now. Because I watch pill counts. I haven't bring medicine bottle in. I do all that stuff. If I got to put somebody on an opiate, even if I think it's short term, they're bringing the bottle in every visit, and we are counting pills. Have to. Absolutely have to. Make sure that you engage the patient in a trial of physical modalities for pain control. It's too easy to hand out a pill. Why are these drugs so attractive? Okay, there's a wonderful study that shows that acupuncture is every bit as effective as ibuprofen for knee pain from osteoarthritis. Wonderful. Problem is, you got to go to the acupuncturist once every week and have acupuncture done. It is too easy to take the damn pill. It's just easy. Same thing with exercise programs. You've probably all at one time or another tried to do an exercise program. What happened? Right? You did it religiously for 2 or 3 days, and then you missed a day, and then maybe you went back, but then you started to hate yourself, so you didn't go back again. And this is the problem. The pills are just too easy for the physicians and the patients to do. But as far as pain control, we know OMT is effective, we know acupuncture is effective, we know physical therapy is effective, exercise therapies, TENS units and more. The list goes on and on and on. The problem is they're all more time consuming, more expensive, and harder to do than popping a pill. It takes commitment on takes commitment on the part of both the doc and the patient to make these physical modalities work. And so what is my specialty? I'm the odontologist. Okay, do I use all these other things? Yes. Do I use my pain management consultants? Yes. Do I use, the pain management folks do implanted spinal cord stimulators, they do fluoroscopy guided facet blocks, they do all kinds of interventional pain management stuff. It doesn't always work. So when it doesn't work, what do you do? Yeah. Say, I'm sorry, but your life sucks, and I'm sorry you got hit while you're riding your bicycle trying to stay healthy, and that moron ran out of their lane and hit your bike, and now you got a fractured pelvis and chronic pain. That's Stephen King, by the way. Did you know that? He fractured his pelvis, and he actually fell into a lovely cycle of addiction. It's out there a lot. You don't realize all the people that are involved unless you watch for it. So, that's it. This is another one of my weirdnesses. This is one of my toys. Okay? When you grow up and you have money after a few years, like 40 years in practice, pay off that last student loan, yes, you get to buy a toy. And so I bought myself a 1959 Buick, just because I thought it was pretty. I don't know a damn thing about the mechanics on it. But it's a rare car. There's about 31 of them in existence. And so, yes, it's a lot of fun. Take it out on the road and watch people swerve to try and, look at that car. Yeah. So I get very good at avoiding. I've been pulled over by state police in 4 different states claiming they had to check my license plate when all they wanted to do was look at the car. So, yeah, it's a lot of fun to drive. So thank you for listening. Thank you for persisting all day in this. And, but I wanted to tell you my story and tell you how the OMT fits into pain management, and it can be used in conjunction with, separate from, in addition to any other modality that you're using. For me, it's whatever works. I've got a patient right now who's doing aromatherapy and swears it's dropped her pain levels by 20%. What are the side effects of aromatherapy? Stuffy nose. I don't know, runny nose if it's irritating enough. That's it. My mother had osteoarthritis in her wrists. They were in an auto accident, head-on collision. She saw the collision coming, she reached out, grabbed the dashboard, dislocated both wrists, developed post-traumatic osteoarthritis. At that time, copper bracelets were very popular for arthritis in the hands. My father said, I'm not paying that money for some crappy copper bracelet, I'll make you one. He went out to the garage, got a piece of electric cord, stripped off the insulation, twisted it all together, made her 2 copper bracelets. He says, try that. It worked. All right? Somebody had demonstrated they cared. Somebody had done something for her in a way that was caring, even if it wasn't, I ain't spending that money. And what are the side effects of copper bracelets? Green skin. Okay, they corroded. So she had very green wrists, but she swore it helped her arthritis. What's the downside? There is none. There is none. So you do whatever works. You do the things that have the least potential for harm, the greatest potential for good. And I personally think that osteopathic manipulative treatment fits into that category. Thank you very much.